Hello everyone, welcome back to InkMed. Today we are going to discuss about one of the most powerful skill for the FMG success, which is reverse engineering clinical vignettes. Many students study thousands of facts but still lost marks because they approach clinical questions inefficiently. They read every sentence with equal importance. They become overwhelmed by the details and miss the clue that examiner actually testing. The purpose of this section is to help you identify those clues quickly and narrow your differential diagnosis logically and arrive at the correct answer with the greater confidence. Let's begin. First, reverse engineering protocol. Before solving cases, let's establish structured approach. First, identify the target of the question. In many FMG clinical vignettes, reading the final sentence first helps determine exactly what the examiner wants. Are they asking for a diagnosis, an investigation, a complication, or a causative organism, or a next step of management? Second, apply the demographic filter. Pay attention to the age, sex, and time course. These details often eliminate multiple diagnoses immediately. Third, identify the diagnostic anchor. Many FMG questions contain a high yield clue such as characteristic radiological sign or a classic murmur or a laboratory findings or a frequently tested buzzwords. Finally, verify every option. The correct answer should be explain all major clue provided in the vignettes. Never choose an option simply because one part of the question sounds familiar. The goal is not faster reading, the goal is more focused reading. High yield FMG diagnostic anchors. Let's revise some classic diagnostic anchors frequently tested in the FMG. When you see a steeple sign, think of viral group. A thumb sign should immediately raise suspicion for acute epiglottitis. An egg on string appearance is classically associated with transposition of great arteries. A boot-shaped heart suggests tetralogy of Fallot. Owl-eye inclusions indicates cytomegalovirus infection. Reed-Steinberg cells are characteristic of Hodgkinson lymphoma. A corkscrew esophagus suggests diffuse esophageal spasm. Tram tract calcification should make you think of Sturge-Weber syndrome. These clues are not substitute for the clinical reasoning, but they serve as a powerful diagnostic anchor that can rapidly narrow the differential diagnosis. Case number 1. The child with barking emergency. Now let's apply the framework to the actual clinical scenario. A 2-year-old boy present to the emergency department at 2 o'clock in the morning with sudden onset of barking cough and inspiratory stridor. His mother reports mild upper respiratory symptoms over the previous 2 days. An AB neck radiograph demonstrates symmetrical subglottic narrowing of the airway. The examiner asks which radiological sign is present and what is the most likely viral cause. Pause for a moment and consider the important clues. Demonstrating case number 1. The steeple filter. Let's reverse engineering the case. First, identify the target. The examiner wants a radiological sign and causative virus. Next, apply the demographic filter. This is a 2-year-old child presenting with barking cough and inspiratory stridor, especially during the night. The clinical pattern strongly suggests viral group. Now identify the diagnostic anchor. The radiograph shows symmetrical subglottic narrowing. This classic finding corresponds to the steeple sign. Once that anchor is recognized, the diagnosis becomes straightforward. The condition is viral group, also known as laryngotracheobronchitis. The most common viral cause is parainfluenza virus, particularly type 1. Notice how the diagnosis emerges naturally when the clues are organized systematically. Case number 2. The post-infection catastrophe. Let's examine a more advanced FMG style vignette. A 60-year-old man develops acute respiratory distress and severe bilateral pulmonary rales 3 days after an inferior wall myocardial infarction. Cardiac examination reveals a new high-pitched holosystolic murmur heard best at the apex and radiating towards the left axilla. The examiner asks which component of the mitral valve apparatus has failed and which investigation confirms the diagnosis. Again, resist the temptation to jump immediately into the answer. Deconstructing case number 2, the axillary vector. Let's analyze the clue one by one. First, identify the target. Examiner wants the damaged structure and the confirmatory investigation. Second, examine the timeline. The patient deteriorates 3 days after an inferior wall myocardial infarction. This timing should immediately raise concern for a mechanical complication of myocardial infarction. Now identify the diagnostic anchor. A new holosystolic murmur heard at the apex and radiating to the left axilla is the classic description of acute mitral regurgitation. The next step is to determine why acute mitral regurgitation has occurred. Following an inferior valve myocardial infarction, the posteromedial papillary muscle is particularly vulnerable because it usually receives a signal coronary blood supply, making it more susceptible to ischemic injury and rupture. Therefore, the most likely diagnosis is papillary muscle rupture, leading to acute severe mitral regurgitation. To confirm the diagnosis, the investigation of choice is echocardiography with Doppler. Transesophageal echocardiography may be used when additional detail is required. By linking the timeline, murmur characteristics, and coronary anatomy, the diagnosis becomes highly predictable. FMG reverse engineering checklist. Let's summarize the process. Step 1. Identify the target of the question. Understand exactly what the examiner wants before analyzing extra details. Step number 2. Apply demographic screening. Age, sex, and disease timeline frequently eliminate incorrect options. Step number 3. Recognize diagnostic anchor. Look for characteristic sign or buzzwords, radiological findings, murmur, and or laboratory clues. 4. Verify the option. The final answer must account for all major findings in the vignette. Following this framework reduces cognitive overload, prevents premature conclusion, and improves diagnostic accuracy under examination pressure. Before we conclude, remember one important principle. FMG is not merely a test of memory. It is a test of pattern recognition, clinical reasoning, and efficient decision making. Diagnostic buzzwords can guide your thinking, but they should never replace your clinical analysis. Always verify that your diagnosis explains every important clue presented in the question. If you consistently apply this reverse engineering framework during your question practice, you will begin to recognize patterns faster, avoid common traps, and improve your accuracy significantly. Thank you for watching. Keep practicing, keep analyzing, and keep thinking like the examiner. I'll see you in the next video. Bye bye.